Yeah, well, good morning, everybody, or afternoon, evening, wherever internationally you may or may not be. As always, I'm Jethro Forbes. I direct the Extracorporeal Therapies and Blood Purification Unit at Cornell. I've been here for about 6 years now, and before that in private practice. And I'm on this journey of learning new and better ways to employ extracorporeal therapies in our veterinary patients. And really appreciative for all of you guys that are on this journey with us as well. And as always, our co-host Cedric down at UC Davis in San Diego. I'll let him introduce himself.
Yes, I'm Dr. Dufayet. I'm the director of the hemodialysis unit for UC Davis in San Diego. And yeah, happy to see you all on a Friday to discuss extracorporeal therapies.
We are, as always, this is being recorded, and so if you miss this session or any other session, if you follow the ACVNU website, there's a link to the YouTube channel where these sessions are recorded and uploaded and there for access at other points in time. Because there's been some really great discussions of late around immune-mediated diseases with therapeutic plasma exchange, and we had some hemoperfusion discussion last week and a kind of a host of different topics. And I was actually, Cedric, I was just back. We had an apical toxicity that almost came to us, and so I went
Ah,
back to watch that session where we had some great conversation around it a few months ago. It was fun to revisit that.
yeah, I keep getting those phone calls, but I haven't had a case materialize yet.
We treated two ethical dogs 2 weeks ago, or a week and a half ago.
Yeah, but you're a case magnet.
I don't know that I appreciate that, Cedric.
That's
Ah, that's
hilarious.
good. I mean, you guys are doing a great job and gather a lot of data, which is profitable to us all. So that's nice.
I know. Carolyn, for what it's worth, in the Northeast here, I used to, always tell people, well, if I needed to go somewhere with my own dog, I might go out of friendship. But now, I mean, Tufts is like, you're there. You guys are seeing everything.
Yeah, we treated a lamotrigine dog again. Again, that was about a week and a half ago. I think it was just a couple days after we treated the apical dogs. The dog got into over 600 mg per kg of lamotrigine, and we ended up basically doing 3 treatments on the dog in 2 days.
Can you tell us a little bit more about was
Oh,
it the
yeah.
characteristics of the drug that had you do 3 treatments or clinical signs or what?
So just as a preface to this, we treated a lamotrigine dog probably about 2 years ago. Lamotrigine is used in humans as an anti-epileptic drug and also an antipsychotic drug. Um, it's The dog we treated a couple of years ago got into 22 mg per kg. The owners noticed almost immediately. They brought it to a veg. The veg then, um, within an hour, the dog was tremorgenic. And it presented within an hour to veg. It was tremorgenic. It started seizing. They referred it to us within probably an hour, hour and a half of it being at veg. Um, by the time it got to us, it was still tremorgenic, almost in status. Tachycardic, eventually went into VTAC, required lidocaine CRI. That dog, we knew nothing about lamotrigine at the time, so we looked at all the PK data up. It's relatively small. It's quite small, so we were like, it could be dialyzed out. It is about 50 to 60% protein bound. So we were like, hemoperfusion might help. Um, so we with the half-life in dogs is not known. I think in people it's a few hours. So we decided that we would try hemoperfusion in series with hemodialysis. We got some really good data. Ironically, the case report was accepted by JVEX a few months ago, so maybe we'll see it in about a year in publication. But the data was really good. It showed that the carbon did a really good job of removing it. That what little was left was also being removed by dialysis, but there was very little left in the dog. So when this dog came in, again, this was a 5-month-old female intact cattle dog mix who the owner had no idea how many pills the dog got into. He just knew that his bottle had been refilled very recently. They were 100 milligram tablets. He took 6, I think twice a day or 4 times a day. He took quite a lot. So the bottle was very full. We estimated that she got at least 600 mg per kg, and she was in Hartford, Connecticut. And for those of you that don't know the Northeast, that's about an hour and a half away from Tufts. They called us and told us that they had the dog. They called Pet Poison Helpline. Pet Poison Helpline told them to seek extracorporeal therapy. So they called us. The dog was apostotnic, somewhat tremorgenic there. By the time it got to us, she was having some seizures, was tremoring quite badly. It's just a lot faster for us to set up the hemoperfusion pump. So we set up the hemoperfusion pump very quickly, got her on a session. Within half an hour, she started to show signs of improvement. She stopped tremoring. Her heart rate, she did come in tachycardic, her heart rate normalized. And she seemed improved. And we were really excited. She sat up. And then probably within a half an hour, she got real quiet again. She laid down lateral recumbent. Within about 20 minutes after that, she had a vertical nystagmus. We were really concerned that she might be re-narcotizing. So we were wondering if we needed to change out a carbon filter. Within another half an hour, the vertical nystagmus went away. She seemed like she might be improving again. Seemed to be having, seemed a little bit better. And ironically, I'm not going to cop to Cedric's title of a shit magnet, but we got a call about a meloxicam dog, and there was a meloxicam dog on the way. So we made the decision that we were like, she on and off still had a nystagmus. So we decided we would take her off the hemoperfusion pump, prime a new carbon, and put her on hemoperfusion and dialysis in series. And then we'd run the meloxicam dog on the hemoperfusion pump, which is what we did. And we figured, seeing as we were going to sit for 3 hours with the meloxicam dog, we might as well do a whole new session with this particular dog. So we ran basically a full second session on her. The first session, we ran just over 30 blood volumes. In the second session, we ran, I think, about 35 blood volumes on her through the carbon and the dialysis. During that treatment, again, in the first half hour, 45 minutes, she started showing improvement. Throughout the session, she seemed like she was better, seemed to be doing somewhat better, still was very quiet for a little puppy. At the end of the session, we were able to assist her to stand, but she was not able to stand well. So we returned her to the ICU. We were hoping just that she would continue to show improvement, but it was reported to us that about an hour later, she was again lateral recumbent with a vertical nystagmus. We came back in the next morning. Our faculty and resident changed. I came in the next morning, and we put her on for another session of hemoperfusion with dialysis, IHD. We did a full 4 hours on her, and I think we did about 50 blood volumes. And by the end of the session, she was able to walk. She was eating, drinking, doing very well. And we were able to send her home actually the next day. So did really well. But yes, 600 mg per kg lamotrigine has showed us that maybe at lower doses you can just do hemoperfusion, but at massive overdoses you probably should do both if you've got the ability.
That's really so many interesting things. I was scribbling notes throughout that. It looks like it's got a pretty, again, all this will be on people, a pretty wide volume of distribution-ish, 0.9 to 1.4 liters per
Yeah.
kg. So sounds like it was probably leaching back out after you were clearing the intravascular space each time, which,
Yeah, that's what we were thinking as well. But also with such a massive overdose that she received, we were just like, we probably just needed to treat and retreat and use every kind of modality we could for her. I did collect samples on her. I just A, we have to find funding to run the samples, and B, I have to find time to send them out.
yeah, I like how you sprinkled in there, the resident and the faculty changed over, but you were the consistent one.
I was on call. We
Uh-huh.
now have more than just me, so it's really nice. But I was on call, and I was the one that was due to come in on Monday morning. So
Oh man. But I mean I think that's a really I mean for folks that do whatever kind of extracorporeal toxin removal, the characteristics of the toxin really help guide some of that and recognizing that the recurrence of those clinical signs may be because there's leaching out. Again, the excessively massive high dose ingested too, but having the wherewithal and maybe even from the start, letting owners know, preparing me mentally, emotionally, time wise, who's on call, as well as owners, financially and commitment wise, and everything else. These signs might come back, and we might have to repeat the treatment, and so we can start to share that experience and prep ourselves for planning ahead for, hey, you know what? If I stay up all night, I'm still going to have to, get a team in here in the morning if these signs kind of come back out again, and the owners as well, so they don't get too dismayed by the frustration when signs return after a really solid treatment on the first or second treatment. So that's a nice illustration of that.
We
And there's
Go ahead,
go on,
Drew.
Andrew.
sorry, I was just saying we had a lamotrigine toxicity a couple months ago. It's an N of 1 for me, and it was only 55 mg per kg was the maximum dose that it could have been. So the dog was symptomatic when it came in. Again, I think it was a young puppy. And we did one hemoperfusion treatment with charcoal, with carbon rather, that was like 18 and a half blood volumes. And that dog with the lower exposure was able to recover with just one therapy session. But I think whenever we get these massive exposures, I think all of what we know sort of goes out the window, and they do weird things. So I'm not surprised that with that huge exposure, they needed persistent treatment. It's great that you guys could do that, Carolyn.
Carolyn's
yeah.
still catching up on sleep. It is great. She's still
Yeah,
sleep
no. We were really happy. We were just very worried, like that she kept kind of re-narcotizing so rapidly, but with such a massive volume, I mean, I feel like it had nowhere else to go. So, it just kept leaching back in. But she did great. And her white cell count dropped a little bit with the lamotrigine. We think it was secondary to the lamotrigine. So we are like, we need to get her out of the hospital quick. So she went home the next day and did absolutely perfectly.
What a great story. Great case.
But yeah, I think I think I think Andrew makes a good point saying that like with high overdose like that, everything we think we know goes out of the window. And especially the half-life might be different, the volume of distribution might be different. Even the protein bounding is probably very different than a therapeutic dose. So we need to look at the pharmacokinetic data to kind of guide like what modality we're going to pick. But then we have to be ready for like the overdose to act a little bit different depending on how bad the overdose was.
Can I ask a random silly question?
Sure.
Um, uh, we were recently going round and round about if anyone has a specific protocol they follow for how long to keep a pressure wrap on after you remove a dialysis catheter when they're going home, especially for the toxins and stuff that are going home fairly quickly, or even if you were to do an outpatient one and they were just heparinized. I know we do outpatient, for dialysis, but the catheter's still in, you're wrapping it and all of that. So I was just wondering if anybody had any certain thing that they followed for that.
So I can speak for the protocol we have in San Diego. I mean, when we do outpatient dialysis, usually we discontinue the heparin about 30 minutes before the end of the treatment. And by the time we wrap the catheter, catheter being still in, usually the ACT is back to close to normal, and we send the patient home just like that. When we remove a catheter, usually our protocol is like somebody's going to apply pressure manually for 10 to 15 minutes. Then we would do a tight wrap around the neck with gauze packed on the insertion site, and we leave that tight wrap for about an hour. And then we would send with a looser wrap the patient home and leave it for about 24 hours, or at least like 12 to 18 hours. And that's what I do regularly when we get cell collections, for example, that come in the morning and go back home we treat them as outpatient. And so far, I haven't had any significant bleeding. I mean, those are like regional citrate anticoagulation too. The one thing that I've noticed with toxicities that we treat with hemoperfusion is that some of them can have a pretty dramatic drop in platelets. And so I've got a couple of cases that were planned to go home the next day. And the ECC team looking at the CBC said, well, we're going to keep that catheter on for 24 hours and we're going to wait a little bit before sending the dog home. Because they were like kind of worried of removing a 12 French in a dog with less than 10,000 platelets. But those are the only cases where we don't like just remove them right away.
So we do a lot of toxicities. Typically, we follow mostly the same protocol as Cedric. We turn the heparin off with the goal of trying to get our ACT at the end of the session close to normal. But generally speaking, if we're removing the dialysis catheter for toxicities, the next day we do check platelet count. As long as their platelet count's over 40 to 50,000, we're usually pretty comfortable removing it. Most of these dogs for us are really young and stupid. So what we've done is we usually give them, if they're young and healthy, we'll give them a mic or two per kilogram of dexmedetomidine. They'll relax a lot during it. Most of them will get nice and sleepy, cause some vasoconstriction. I can then remove the catheter, apply pressure for a good 10, 15 minutes. And again, like Cedric, once we're done applying direct pressure for 10, 15 minutes, I'll put a pressure wrap on them. I'll usually leave that on for a minimum of 2 to 4 hours. And then I'll send them home with a lighter wrap, and we have instructions if the owners remove the wrap the next day. But I usually like to give them just a little something to relax them, maybe cause a little vasoconstriction.
Yeah, I've had some of the crazy young healthy toxins. I've had to put some sutures, extra sutures in before they left because they're jumping around, acting crazy, and nobody wants to remove those catheters until the very last second. So sometimes the owners are in the door and they're like, yeah, but they really have to go now. And I'm like, you can't do this.
Well, I mean, there's also nothing wrong. I do just for conversation. I do very similar to what's already been described. I'll get a nice pack. I like a roll of I get sterile cast padding, and because it fits really nicely in that jugular groove, and I'll send that home in the wrap. Not quite as tight as my initial one for the first couple hours. But I mean, if they don't live too far away and there's this urgency, I have sent home with a catheter for the day and then take it out the next day when there's a little more time. And I'm happy that, all that heparin has been metabolized. I've been finding, and this is a different species altogether, but I've been finding with some of the calves that we've been treating that they have a rebound effect of the heparin even after their ACT is getting closer to normal. And maybe it's just the high doses that we're using those guys, but it has made me think about when it's time to pull that catheter. And if they live 5 hours away, it's not practical to come back the next day, but that would be another option too if people were worried about it. And then the only thing with putting in skin sutures is that it's not so much the skin for me that I'm worried about as much as it is the, the vessel being, getting a good clot on it, I guess.
Yeah, that was my only best thing I could do at the time. I couldn't think. I'm like, oh goodness, they were very
But
insistent.
I kind of agree that like need to educate the hospital team and the owner about no, we cannot remove those catheters and just let the dog out of the door right away. Uh, I mean, definitely like again, the cell collections, usually we finish them around like 2:30, 3 p.m., but the dog's not going home before like 4:30 because we want to apply that manual pressure. We want to put that pressure wrap for at least an hour before we're comfortable sending them through the door. And usually we just like, when we change that tight wrap to the lighter wrap, you just like check the side, see if there's any sign of bleeding or anything like this. And usually I'm pretty confident sending them home, always with some instruction that if they see any bleeding through the bandage, that they go to the nearest emergency room. But knock on wood, so far so good. I haven't had any patient needing that.
And there's been a couple of one-offs that I've heard from other folks. I've been lucky as well. I'll say that.
I mean, you're bound to have one of these days
Yeah, if you do
at
enough, you're
some
gonna have
point.
one. Yeah.
Yeah.
The other consideration, if we're talking about, something that might have a nephrotoxic potential in terms of a toxicity that we treat with hemoperfusion or some other extracorporeal toxin removal modality, I mean, I'm one of those like hedge my bets and, if I want to check blood work the next day and make sure there isn't an AKI that could lead to the need for some, renal replacement therapy or trend in that direction. Sometimes there's a little bit of a, superstition in me, a little bit stitious. But again, it's all dependent. If they've driven 5 hours, we've got to figure out something different than that for sure.
Yeah, I would definitely do that too. Like if we get like a massive, I don't know, ibuprofen toxicity, for example, even if we get them the right time, I'm pretty confident that we did a good job with TP or hemoperfusion. Usually I leave the catheter in place until we're sure that their renal values are not trending up, just in case the dog would still get a bad AKI and would require dialysis a few days later. And very similar to Jethro, just like leaving the catheter in place makes me think that that's not.
Definitely wards away the evil spirits of AKI.
Yeah, for sure. Is there anything anyone follows in particular if you have to do like an outpatient hemoperfusion where they can't afford hospitalization?
I saw
Uh,
Drew looked like he was gonna unmute there.
I was just gonna say that I actually try to keep I've sent one home the same day, and it was a cell collection. It wasn't a toxicity. I think the few times that I've been like, I don't want to say burned, but where I've had to pay more attention once I've pulled out the catheter was, I had a couple of dogs that were NSAID toxicities, and they just like they had enough platelets. Their ACT was fine, but they just bled afterwards anyway. And so I ended up like being a little bit more worried about those catheter sites and having to like have the bandage on a little bit longer in hospital before I felt going home. And then, I think more that I do it, I recognize the shift. The first time that happened to me, it went from like, 175,000 platelets before, and I was just like totally caught off guard by that, sitting in the hospital before I pulled it. And so I think just like having that on our radar as a thing that happens, even if I rinsed back and I tried to get as many of the platelets out of the filter as I could, but at the end of the day, like especially with I think some of the ibuprofen or other NSAID toxicities in dogs that are already more likely to be hypercoagulable from both being a dog and then also being an NSAID toxic. I think it's just like we were saying before. I think it's a little bit of a crapshoot, and I think there are things that we do routinely to try to mitigate risk, but I guess I don't think any case is like totally the same, and I have the same thing that works every single time.
Yeah, I think that highlights, as we all do in veterinary medicine, having a plan B and C, and it's certainly my complications and my bumps in the road have shaped my practice and my awareness of being prepared for some of these glitches. The other thing, platelet counts, but also, NSAIDs and their ability to cause a platelet dysfunction as well in these massive overdoses. Who knows if that's also contributing to some of that risk too. So lots of different factors there. Carolyn did put in the chat there that they're on the superstition bandwagon and keeping the catheter in place until kidney values are rechecked. Brooke, what are some of the the states your outpatients, are they coming from a distance away? Is it impractical to have a plan B there and leave the catheter in and pull it the next day instead? Keep them for a couple hours tomorrow instead of keeping them for a couple hours today if there's a rush?
Yeah, for sure. I think that would be some are coming from far away but a lot of them aren't. I think that would be definitely a reasonable option to do that for sure.
Or, as Cedric said, it's kind of building the understanding in the timeline for your hospital team and the clients, as well, that
Oh yeah.
we need this window after.
I think a lot of the toxicities that we're treating, they always come at night, first of all. So we usually start the case around like, I don't know, 10 p.m., 11 p.m., if not later in the night. And so usually I would say that most of the cases go back home during the early afternoon shift the next day. So they're not even staying 24 hours. Like we get them in through the door, we do the treatment, we go get back some sleep in the morning, and the dog maybe stays another like 6 to 8 hours, and everything looks good. Most of them just go home. So yeah, a lot of them I would qualify that as outpatient because they're not really staying in the hospital that much.
I wanted to go back to Carolyn's case example here. There were a couple of things that I think were cool to point out there. You said pet poison control was already recommending, pursuing extracorporeal toxin removal. I'm finding more and more I'm getting referral vets that haven't given that advice. So it's definitely infiltrated the poison control lines, which has been great to see.
There's definitely been a shift in the last few years where like poison control would never ever talk about extractables therapies, and now they do. Sometimes they don't give the exact right recommendation, but at least we get the phone call and then we can discuss it over the phone, which is great. But again, I mean, I'm going to sound like a broken record, but we can't really blame them for not recommending extractables therapies when we don't do the job of publishing like robust evidence. So it's kind of like, if we want poison control to jump on the bandwagon and recommend extractables therapies, then we need to bring them the evidence that they can make that recommendation, because it's you get some peer-reviewed papers behind it.
That ties into the other thing I was going to point out from Carolyn's discussion of that previous case report that they're waiting on JVEC for. I'm trying to be better with the reviews. I'm a week late for one JVEC review now. So I mean, some of it's on us ourselves to prioritize doing those reviews to get them out, prioritize the reports and the publications and submitting them, but also on the reviewer side too. I know that's we're also busy. It's another holdup.
But if you can't wait for the JVEC to publish your case, just present it on the Friday morning.
Bingo. Put it out there.
But you get the information out. So
Hey, Carolyn, I'd love to. Cedric and I got an email from somebody this morning. I don't see them on the call. Oh, well, Polly's on there. I mean, there was a question from somebody else just about integrating some of the hemoperfusion devices into other platforms and other circuits. Um, you guys, it sounded like you put it into. Did you put it into your Blue Star? Is that what you did the combo HP IHD with?
In this case, yes, it was into the Fresenius Blue Star. In combination, we did intermittent hemodialysis session in series with carbon. Um, I think the email you're speaking of was from Dr. Mitchell Fultz. He's in out west. I think he's in Oregon. He's in the Northwest. I guess he was having some issues with some clotting in his circuit when he was putting the carbon device in line in series to perform hemodialysis. He says he's done it in in line with TPE and didn't really have too many problems, but he was having a lot of increased TMP problems with running it during PIRRT. So he had some questions, and I think the experience that we're finding with any of the adsorbent columns is that when we put them in series, we're just finding that we have to be more diligent about heparinizing our patients, getting their ACT actually to above that therapeutic dose, actually not starting them until we're well into or above what would be a therapeutic ACT. So for us, that's getting them above 170, usually around 180 to 200 before we even start them on the therapy, because I think, especially those patients for us that are going either on, in series, we do a lot of in series toxicities. We have done them like this lamotrigine dog, but those dogs that are needing it, where we've been using it as therapeutic for, I don't know, cytokines or whatever in our Prismaflex or in our Blue Star, I think we tend, I think, to have at the start a lot of stop and starts. The catheter is not working right. The patient's, we have to slow the QB down because the patient's not reacting well. And so I think we just end up with a lot more clotting. I think because we're stopping and starting the flow, you're getting kind of that variable flow. So sometimes the fibrin that might be in the blood starts sticking to that bottom screen on the carbon. And, because you stop, you start, you stop, you start, you don't have that really nice kind of laminar flow. And so my advice to Dr. Fultz, just from my experience, was I felt like just heparinizing them greater, doing kind of a greater heparinization, start them a little higher, and then, watch for bleeding and bring them down slowly. Like, that was my advice.
Yeah, I mean, we monitor the pressures on the standalone hemoperfusion platforms, and we see that pressure difference across the columns, the devices. And so translating that and putting that into a circuit that's sensitive to excess pressures, whether you're the heparinization plan is I think a big part of that with and without multiple devices or platforms or modalities. But it certainly makes some sense that the machines get a little bit finicky about them. Are you, and I think we touched on this a little bit, a couple weeks ago. I have traditionally always put my extra device, hemoperfusion device, typically pre-hemofilter, hemodialyzer. Is anybody doing anything different that way? Because I thought that might have been an email too. Was he putting his post somehow? Did I misread that?
Yeah, it was placing it post. I
We've been
usually place it pre, but
Same.
we've been also in the habit of running the treatment for about 15 minutes before even adding the device, the carbon device. And that's been
Yeah.
avoiding a lot of clotty kind of issues for us.
Yeah. And I don't know if it's you, but mentioned that last session, somebody mentioned that too, like waiting before they would include the carbon device. It's just like, it's just an extra step that I feel like is very annoying. Like I'd rather like prime the whole circuit in one, but I definitely concur. And I've had the same experience too. We treated a cat, I think, for meloxicam toxicity, and we needed to blood prime the cat. We used the small carbon cartridge on the Revive, and we clotted the cartridge like pretty much right away. And I don't know if it's because of the blood prime, because we didn't like reach target ACT soon enough. But on that same night, I had a call from my former fellow, and she was about to start a treatment on the Prismaflex, I think, and blood prime. And I told her like, well, maybe just like run that blood for like 15 minutes before you insert the carbon cartridge, because I suspect that my blood prime didn't go as well as I wanted. And she did that, and she had no problem with clotting. And I think Caroline mentioned too that
Yeah, that was
she was
our
adding some
case.
heparin to the and so and I think Caroline mentioned when we discussed that they were also adding some heparin into the blood prime. Am I right, Caroline? When
Yeah,
you're doing
we do
blood prime and
that.
the carbon?
Yeah, if we're blood priming carbon, just because what's in the blood that you're priming has citrate, and you have not primed the
Yeah.
carbon with citrate. So we found that we had a lot of clotting problems, and then we started adding heparin to our blood prime, the actual blood that we were priming, and we have not, knock on wood, we've had a lot less problems with it. I'm up to, at first we started with, I just take the patient's body weight and do 10 units per kilo, but I still found that we were having some clotting. And so now I'm doing 20 units per kilo into the blood prime, and I have not been having those same problems.
And are you still priming the patient as you would usually do, like 25 to 50 units per kg,
Yeah.
or are you just like,
Yeah.
okay,
Yes, I
so
am.
it's on top of the usual prime?
It's on top of the usual prime. We've had a couple of patients that their ACT goes up pretty dramatically, but I mean, we're going to be sitting there for the next 3 to 4 hours. So I'd rather it go up and not have any clotting issues or lose the circuit. And I can bring that down, over the next 3 to 4 hours.
And regarding the pre or post filter, I know that Dr. Cargill also mentioned that a couple of times, but when we do hemoperfusion, the IHG platform, we tend to put the carbon cartridge before the dialyzer. And one of the problem you can get if you put it after the dialyzer is that you can get high pressure within the hemoperfusion device, which will not be detected by your IHG platform, and that can cause like massive ultrafiltration. Because it's going to put some pressure on the membrane, which is then before the hemoperfusion device. So definitely putting it before the dialyzer on an IHT platform is the safest way to go.
Not quite related, but somewhat tangentially. You guys might laugh at this. We've got this calf LPS sepsis study we're doing, and on my starting dose of heparin bolus for those guys is 300 units per kg to get them to just above. I'm trying to get them to 350, 400 ACT if I can, and sometimes it's taking 2 of those boluses to get there. Our little girl from this week did just fine. We got her up to 450 with that 300 units per kg initial bolus. But the dramatic difference in scale that we're finding we need in these guys is really impressive. I'm telling my large animal folks, don't think this is what happens in the small animals where it's 25 or 50.
I feel like I've started, especially on like IMHA cases, going closer to like 50 to 100 units per kilo as my starting bolus. And even with that, I'm still probably like, I don't target anything over 250. I'm usually in the like 180 to 220 range, and occasionally we'll end up, after a bolus, kind of in that 300 range, but not commonly. I've been surprised about how much. It's because before I started doing this, I didn't use a lot of heparin clinically, even in the ICU. So I've been a little surprised how much you sometimes really need to get these guys in a place that's safe to start. And I totally echo that sentiment earlier of not starting too soon, because everyone's eager to get the machine going, get the procedure started, and if you start before your ACT is in that therapeutic, or above that therapeutic range where you're less likely to clot, you really just waste an hour and $1,000 on the device and have to start again. So I think that was one of the lessons I learned kind of the hard way early on, was be patient with the heparin, get to where you need to go, and then start the procedure instead of trying to rush it.
Yeah, I think it's even more true for hemoperfusion than for dialysis. Like sometimes dialysis is going to give you a little room to play, even if you're not right on target when you start, but hemoperfusion doesn't forgive much. That's my impression.
Drew, or anybody, how long do you give after your initial heparin bolus to recheck that ACT?
I usually give that initial bolus like right as we are, um, like getting. So we sometimes we'll place the catheter in a different place, or we'll have come back from taking the placement rad for the catheter, and so usually within I'm thinking we're going to start the procedure in 15 to 20 minutes, and so I'll give that bolus and then recheck right when I'm about to start. Usually, like I said, within like 15 or 20 minutes, I wait at least 5 minutes to check. It sometimes is 15 to 20 minutes. And if I've gone beyond 20 minutes, I recheck before I start, to make sure I don't need another little bolus, because I don't always run the CRI in the background. Although I've done that on the last couple. It's like I get to a place where I'm happy and then I run a CRI, even if we're not quite on the machine yet, just at like a low level to keep us in that range so that I don't have to play this yo-yo game. But I don't know. It's probably something that I should do slightly more consistently than I do, but I feel like there are times where I think everything's going to go one way, and then there's a line at radiology, or there's something happens and the plasma's not totally thawed yet for TPE or whatever it is that throws the timing off. And so I feel like I some degree kind of make it up as I go, but I think I give it at least 5 minutes after the bolus to check, and then we'll wait, up to 15 before starting if I think it's in the same range, and then I would check again to make sure we were still in the same range if I waited beyond 15 minutes.
Yeah, I think that makes sense. I'm always I'm impatient. I'm like, okay, I gave the bolus, make sure I flushed it really well through the catheter so I'm not contaminating my ACT sample that I pull from it. And like, oh, how long do I have to wait? Well, cardiac output delivers it around the body pretty quickly, and its time of onset is pretty rapid. But I always feel like I'm tapping my toes, going, okay, it's maybe been 2 minutes. Maybe I should wait till 5 before I make sure that it's actually had its effect. But at worst, I'm gonna, give them a little bit too much, and I'll overshoot a bit. And as Carolyn said, I'll be sitting by them for a few hours, so I'll be able to manage whatever overshooting I do in that time frame. Well, there's a few other I don't know, Christine, are you out there? Have you guys been treating any cases? We got like 10 minutes to go here. Is there anything interesting that you've come across recently? Christine may be doing what I do, which is have the meeting running in the background and juggling all the other demands on our life that there is.
I'm just gonna throw out there. I've started heparinizing a lot of. So we have an amicus, a Fresenius amicus, as our apheresis platform. And it's a regional citrate, but I've started using a heparin CRI in the background, not as excessive as I would if I was just doing, a hemoperfusion case where that is my full form of anticoagulation. But I feel like especially in the beginning of a TPE case where maybe I'm not going to be able to flow as fast because everything has to sort of equilibrate. The dog has to get used to it. I'm not having like quite the same initial return back to the dog and flow through the circuit. I think it's helped me be less clotty in some of those cases early on. I don't always have a CRI going in the background if it's like just a collection, like an MNC collection or something like that, but I will still heparinize the dog in conjunction with, even if just a bolus, in conjunction with putting them on the regional citrate. So I think it gives you like one more little layer of protection from clotting. And I guess to me, it sounds like the group in general, like we're pretty comfortable with what these guys do on the machines while they are anticoagulated, and our ability to manage that is somewhat easier, I guess, than having to start over or lose a circuit or lose the whole product. And so I guess it's sort of forced me to learn a new level of comfort with heparin and the ACT, but it's one that I think as I've gotten more comfortable, I'm willing to take, I don't want to say more risks, but be a little bit more aggressive with the anticoagulation. And I think I've had an easier time on the back end as far as like getting the catheters to flow well and not clotting. As I was just saying this, I realized something else that I've started to do slightly on accident, but I've been pleasantly surprised when it's happened. A lot of the times if I have small patients, I've placed the catheter in the caudal cava and reversed flow, and I've found that I have a much better flow when I'm in the caudal cava than if I'm in the cranial cava. Do you guys notice that?
I wonder how much of that is a function. I enjoy a caudal vena cava catheter as much as the next guy, or person. I wonder if it's, I found it's sometimes just a function of where on that catheter you're pulling from. Instead of the side ports, it's that distal port where it's less likely to get sucked up against the sidewall.
That's my feeling too, especially when the ratio of size of the catheter to size of vessel is close to 1. Usually you sucking on the wall pretty fast, and just like changing that, your return is actually going to keep your catheter away from the wall, and then you're sucking from the central. So that might be one of the reasons as well.
Yeah, it's been consistent, and the first couple times it was just a small dog, and it was the catheter I had, so we did it, and I've done it intentionally one other time, and then the rest of it's sort of like, well, this is where we ended up. But I've never been sad that it's been in the caudal cava.
No, for sure.
Folks, the folks.
And just
go ahead, Cedric.
No, I was just like gonna say like it's very similarly like when I have a patient that I'm gonna either do TP on the Optia or cell collections, I will prime them like I would do a hemodialysis cases with like 25 to 50 units per kg, just to kind of like smooth out the beginning of the treatment. And then they are like very small dogs where sometimes you struggle to get a blood flow more than like 8 or 9 mils per minute because of the citrate return rate. I tend to put them on a CRI as well because I've had cases where the blood would clot before it reaches the hub where the citrate is reaching the blood. And so like the small patient with very slow blood flow on the Optia, I tend to use a CRI as well. But I'm targeting like an ACT. Then my target ACT is like 150 to 160. I mean, I just want the blood to be anticoagulated for the first 20 centimeters of the circuit. So I'm not going high, but it's just like in the background, and especially in IMHA dogs that tend to be very clotty. I think it helps a lot.
Yeah, I've heard, Cedric, I've heard, I think you talk about that before as well. There's that segment just prior to where that citrate joins the circuit that has been a problem spot for clotting for you and maybe other folks too.
Yeah.
Well, this has been great. Again, another good group think chat here, and some really cool stuff from Carolyn's case up at Tufts. Both the one that happened this week and one from waiting to be published a little while back, and MedVet Columbus coming strong. Drew, I saw you unmuted there. Did you have something else to add?
No, sorry, I was actually remuting.
Oh, gotcha. Brooke, some great questions and discussion leading input around catheter removal and time to go home and bandaging, and sounds like a lot of us are doing things somewhat similarly there. I
Well, I think
will.
we've all been trained the same way, but everybody has some like personal tricks, and that's always a nice thing to share because I love picking some good ideas from some of the centers because when you do things the same way every single day, I mean, sometimes you don't get that creative and somebody else can come up and you say, wow, that's such a great idea. Let's adopt that. So thank you for sharing.
And I'll say this because he's not here. I think most of us are on the Larry Cowgill, tree of coaching / training. And that doesn't mean that he's got all the answers. So new, fresh look at stuff is always awesome to have and incorporate. On a little bit of a note here, Cedric and I are both heading to IVEX in Savannah, Georgia, and we're brainstorming on some ideas to get some maybe live, maybe recorded kind of interactions with folks there. So if you guys, anybody on this call or anybody who might watch the recording of this might be in Savannah coming up in September, we'd love to interact with you, get you on camera for a little bit, maybe have a little bit of fun with it. And yeah, so I don't know, Drew or Jay, are you guys headed to IVEX?
Well, I didn't miss it.
Nice. Carolyn, are you guys sending a team?
Our ECC is going, but so far I don't think anybody from the ECT program's going. I was at ACVIM, so only so much CE money in the kitty, but so I don't think
We'll see
anybody.
you at Renal Week.
I will be at Renal Week.
So leads right into the next plug, which is make sure you're looking ahead to registering for Renal Week, where we will be having a couple of live Extracorporeal Hour sessions, lots of labs, great conversations, lots of learning to do. Just bringing our community together, which is great in this format, but even better when it's in person. And Friendship does a really awesome job with this event. Hemodialysis Academy is still open for registration. Cedric, do you know, is there a cutoff to registering for that?
I think up until the very last day, you usually enroll, and the start date I think is September 27th or 28th. So that should still be some time.
Right. And if anybody out there has anybody with critical care background specifically, I'm just about to post a fellowship up here at Cornell. Trying to time it with starting the Hemodialysis Academy as well, because that'll be part of this program's requirements. So certainly send them my way if they have questions about it. I'll be trying to get that post out on a couple of different listservs as soon as I can get the details sorted. But it will have some ECC oversight with residents. So we'll be selectively looking for somebody with either a diplomate of VAC or somebody who's board eligible for that. So yeah, send them my way if you guys know of anybody. And with that, thanks for everybody's time, participation. Look for the recording. Send Cedric and I, examples of cases you guys want to chat about. It can be off the cuff or it can be a presentation. we're all here to learn, as hopefully you guys have all noticed today. We picked up a lot. So I'll sign off there, but Cedric, I'll leave the final word to you.
Yeah, well, nothing else to add. It's always a pleasure, and I'm looking forward to seeing you all guys in 2 weeks. I actually had some material prepared for today. I didn't have to use it, so it's great.
Oh, cool. And we'll look forward to 2 weeks then.
We'll see. All right. Have a good day, y'all.
Bye, guys.
Yeah, thanks.